Hello distinguished committee members, my name is Karina Farah El-Haraki. Today I present my master's final dissertation, A Comprehensive Approach to the Face, Anatomy Applied to Combined Aesthetic Techniques. This systematic literature review examines how anatomical knowledge guides safe and effective combined aesthetic protocols. Contemporary aesthetic medicine has evolved from single modality treatments to comprehensive combined approaches, addressing multiple aging dimensions. Understanding anatomical foundations is critical for three main reasons. Firstly, for patient safety, preventing vascular complications requires detailed knowledge of facial danger zones. Secondly, in treatment outcomes, achieving natural results demands understanding facial compartments, tissue layers, and aging patterns. Thirdly, diversity, ethnic and gender variations require individualized approaches. There is a significant gap in literature. We have limited evidence on the safety and efficacy of combined treatment protocols, which motivated this review. My objective was to analyze literature on facial anatomy for combined aesthetic techniques. This includes 5 specific aims: to describe fundamental facial structures relevant to aesthetic interventions, to evaluate age-related anatomical changes and treatment implications, in comparing combined treatment protocols, in identifying variations across ethnicities and genders, and to access safety considerations and technological advances. I conducted a systematic literature review analyzing 25 peer-reviewed references. Sources were obtained through the University of Chichester's online library, accessing the Directory of Open Access Books, the Directory of Open Access Journals, and Oxford references. The distribution shows 40% of the references are from 2024 to 2025, capturing the most current research. The concentration in recent years reflects the rapidly evolving field. This shows our 25 references across different evidence types. Most are original research studies, 44%. We also have a systematic reviews at 12%, plus narrative reviews, atlases, imaging studies, and guidelines. The key point: we have good anatomical research, but we need more high-quality clinical trials. My first key finding addresses facial fat compartmentalization. Traditional teaching described facial fat as continuous. Contemporary understanding reveals that facial fat exists as discrete compartments, which age independently, creating specific volume loss patterns. The clinical implication is profound, targeting volume restoration rather than generalized, representing a shift from empirical injection to more anatomically guided precision. Vascular safety represents the most critical aspect of practice. The danger zones include the glabella, the nasolabial fold, and the temporal region, all high-risk areas. Prevention requires detailed anatomically knowledge, precise techniques, and ultrasound guidance for high-risk areas. This diagram illustrates critical facial vascular architecture. The supratrochlear artery, the supraorbital vessels, the temporal vessels, and facial arteries create a complex three-dimensional network. The glabella is considered a high-risk zone. Its artery connections allow retrograde flow to the retinal circulation. Complications from vascular occlusion can be devastating, potentially leading to tissue necrosis or even blindness. Mitigation strategies include detailed anatomical knowledge and ultrasound guidance, though I should note there's a significant gap in data regarding ultrasound effectiveness in routine clinical practice. The recognition of vascular occlusion is time-sensitive. In the first 6 hours, blanching, severe, disproportionate pain, slow capillary refill, dusky appearance, and cold skin are signs to monitor for. After the first 24 to 48 hours, one may observe tissue discoloration. After 72 hours, they may result in pustules, tissue necrosis, or even permanent scarring. In emergency management, one must stop injection, massage vigorously, administer hyaluronidase if necessary. A warm compress can be applied, aspirin should be administered, and immediate specialist referral. Moving forward, my key finding examines the anatomical rationale for combining different treatment modalities. Expert consensuous support, synergistic combinations in the adaptations of neuromodulators for muscle relaxation, hyaluronic acid fillers for volume restoration, PDO threads for tissue repositioning, and biostimulators to stimulate collagen production. The rationale for combining these, each addresses different layers and aging mechanisms. Current evidence is limited mainly to expect, consensus and case studies. We have a significant gap there. There's a lack of randomized controlled trials on combined approaches, and we don't fully understand the vascular risks supporting the synergized combinations. Evidence remains incomplete, relying on anatomical rationale rather than clinical trials. In ethnic variations, we require careful consideration. In Asian populations, characteristics include a flatter midface, lower nasal bridges, and thicker dermis. African populations display fuller lips, wider nasal base, a higher post-inflammatory hyperpigmentation risk. Caucasian populations portray thinner dermis, more anatomical variations, significantly more lines, and may age faster. Individualized protocols are essential. The Fitzpatrick scale. The Fitzpatrick scale provides our framework for skin type classification. Type 1 is light, pale, always burns, never tans, the thinnest dermis. Type 2, fair, usually burns, tans with difficulty. Type 3, medium to olive, mild burn, gradual tanning. Type 4, olive, rarely burns, tans easily, common in Asian and Latino populations. Type 5, light brown, very rarely burns. Type 6 represents dark brown, never burns, the thickest dermis, highest PIH and keloid risk. Gender differences represent another critical dimension. Sexual dysmorphism in facial anatomy is significant. Female anatomy offers a softer jawline, higher cheekbones, and a V-shaped architecture. The masculine facial frame are depicted by more angular jawline, prominent brow, deeper temple, a square face, and more defined bone structure. For treatment implications, volume loss patterns may differ. Distribution must be tailored as such. Contouring techniques may vary. Ignoring these differences may produce unsatisfactory outcomes. Gaps and limitations. The review acknowledges several limitations. Limited high-quality trials, focus on Caucasian females, darker skin types are underrepresented. Subjective outcome assessments. We need more objective measures. Publication bias, potentially optimistic views, literature review constraints, and the rapidly evolving field requires periodic updates. Despite limitations, this provides a comprehensive cynicism for evidence-based practice. Looking forward for future research, 4 priority areas for research emerge: prospective studies on combined treatment outcomes, standardized anatomical assessment protocols, an individualized approach to each patient as ethnic variation studies with truly diverse populations, and validation of technology, integration, and ultrasound. In conclusion, this review demonstrates that comprehensive knowledge is essential for safe, combined protocols. Fat compartmentalization enables precision restoration. Vascular anatomy understanding prevents life-threatening complications. Ethnic and gender variations demand individualized approaches. Combined modalities offer integral benefits for a synergized approach. However, significant gaps remain. We lack randomized trials, long-term data, and validated protocols. Bridging this gap represents our greatest challenge and opportunity. In acknowledgement, I extend my deepest gratitude to Dr. Juan Guzman, my supervisor, whose guidance elevated this work. I thank CEMP, the Centre for European Masters Programme, and the University of Chichester for essential resources and library access. I am grateful to Dr. Alessio Radelli for his pioneering work that advanced this field and inspired this research. I dedicate this to my grandmother, who sadly passed away during my study, whom sat beside me during my writing. Her love inspires me. This program profoundly shaped my understanding of evidence-based practice in aesthetic medicine. Thank you for your attention.